So welcome back everyone. So now may we move on to the presentation section 4 on management of dyspnea. So it's my pleasure again to invite Dr. Andrew Binks to moderate this section. Dr. Binks, the floor is yours.
Thank you very much, Naomi, and welcome to our last session with abstract presentation, addressing the third pillar of the Society's aims of management. So we'll start off with our first presentation from Tanya Palmer, who will give us a systematic review of the effects of exercise rehabilitation on exertional dyspnea in chronic cardiorespiratory populations. Take it away, Tanya, and welcome.
You're just muted. You can unmute.
Perfect. Sorry. Everyone can see my slides?
Yeah.
Perfect. Thank you. Everyone keeps saying good morning. In Australia, it's actually quite late in the evening, so I'm going to say good evening. Like Andrew said, I'm presenting today on a systematic review that we're still currently completing, so it's quite emerging. And it's quite point, I guess, in the conference to follow on from Isaac's presentation. And this systematic review is sort of a part one of the larger systematic review that we published back in 23, looking at the fixed intensity exercise test to measure exertional dyspnea in chronic lung and heart populations. So for those of you who don't know, the lovely starburst chart that's becoming quite popular. So within this study and part of my PhD, which is looking at validating an exercise test called the Dyspnea Challenge, which is one of the emerging fixed intensity exercise tests, we highlighted that there's the need to evaluate and look, I guess, a little bit deeper into the impact that exercise interventions does have on exertional dyspnea when you're measuring it during the fixed intensity exercise test. So hence this other systematic review. Now it is Prospero registered. So what we're up to at present with this is we've undertaken the systemic searches in 5 of the electronic databases, as you can see here. Inclusion criteria is very similar to the larger 23 publication in that we're looking at only exercise intensity or tests that were fixed intensity and that measured exertional breathlessness. So if they were a constant rate exercise test till exertion, did they have ISO time exertional dyspnea measured throughout? So there's a lot of trolling through these articles to try and find that detail because it's not always reported. What we did look at, though, too, is we broke it down into a little bit of a sub-analysis when we did look at it at the intensity of the exercise training that was completed. So whether that was low intensity of less than 60% of their peak work rate. And most of these studies were done with fixed intensity, yes, but they had already completed their maximal intensity exercise tests to work out the constant rate. Then the high intensity we looked at was greater than the 60% peak work rate. So what we found to date, and sorry, these tables are quite busy, is that we've currently got 24 articles that we've found out of the 7,525 that the database has returned. 21 of those were found within the database search and another 3 were sourced from previous and other sources. So in the current 24 articles that we've got, as you can see, 23 of those were done in COPD and only 1 was done in the chronic cardiac, and that was in the heart failure population. Now, the exercise interventions that we found, there's significant heterogeneity in those. And most of the studies, as you can see in the intervention duration, were around that 8 to 12 week duration, with some of them were shorter at 3 weeks. And most of them completed 3 days per week of training. So quite intensive if you're looking at it, a little bit more than the common pulmonary or cardiac rehab of your 2 days over your 8 weeks. So what we also found was that the time of training changed significantly. Some were as low as 20 minutes and some were up around that 2.5 hours per session of training. With the work intensities, it ranged significantly as well, from some articles reporting as low as 8% of their peak work rate. And that was an article based around heart rate intensity that they were looking at, but they did equate it to what their peak work rate would have been. And then you've got some that were working at intensities of up to 140% of their peak work rate in those incremental exercise tests. So of the 24 studies, most of them did exercise them at high intensity, so over that 60%. Modalities were different, obviously. Most were done in cycling. There was some treadmill studies done, about a third of them. And there was, interestingly, one done in the pool and one done with just pure upper limb. It's a bit of combination between cycling and resistance. And in true cardiac or pulmonary rehab format, there was resistance done in half of the studies. You can see here we've broken it down into each of the studies themselves as to what was low intensity and then high intensity, and the pre and post Borg. And if you just quickly flick down through, most of these studies were deeming that the exertional breathlessness was reading significant after the intervention. The high intensity protocols did show the greatest reduction in exertional dyspnea, but notably even the low intensity studies, even though there's less of them, still showed that there was improvements in people's exertional dyspnea. Now, all of these studies did report it on the modified Borg scale. So to conclude, there is significant heterogeneity, as we'll know, in the approach of our exercise interventions, but we did find that the higher intensity programs, regardless of the exercise modality and length of time, did yield the largest improvement in exertional breathlessness.
Thank you, Tanya. Very, very interesting. So we'll open it up for questions and discussion for a few minutes. Rochelle, please go ahead.
Hi, this is great. Good job. I'm wondering, maybe I missed it, but I don't think I did. I'm wondering if you have any results on if exercise endurance time was improved alongside significant differences in dyspnea. Having done an exercise training trial myself in the last 3 years, I know how hard it is, I guess, sometimes to improve exercise endurance time as well as dyspnea, but wondering if that was reported.
We didn't look at it, but most of the studies do report that there is significant improvements in endurance. Obviously, we're looking at the fixed intensity, so I'm not so worried about endurance, but rather that pure exertional breathlessness.
Okay, thank you.
Are there any further questions? So I'll ask Tanya, your literature search really sort of brought up the COPD population, but very little of the cardiac population. Do you have any insights into why?
Even in the biggest systematic review we did, there was very little done in the cardiac population. And I don't know whether it's because of the fixed intensity exercise tests that we narrowed it down into, that most of them weren't done in the cardiac populations. Because by memory, even in the big systematic review, there was less than a quarter of the 120 something articles we found were done in cardiac as well. And that's all we could conclude. That was, they're looking at mainly the CPET sort of, interval and endurance tests rather than the fixed intensity. Now, the biggest study that we're doing with the dyspnea challenge is looking at heart failure. Slightly harder population, I can tell you, to recruit, finish rehab programs, but also report consistently breathlessness. So I don't know whether that has an impact as well.
Okay, thank you. Okay, we'll try and stay on schedule and move on to our next presentation. Priming tasks decrease effort perception in loaded breathing in people with chronic obstructive pulmonary disease, and that will be presented by Molly Eve Day from Flinders University. And I should say good evening and welcome.
Sorry, can you hear me?
Can't see, we can just hear you now. Excellent.
Can you hear me? Can you see me now?
We can. Thank you.
Excellent. Okay, thank you. All right. So many people with chronic obstructive pulmonary disease live with debilitating breathlessness, which causes significant distress and negatively impacts their quality of life. Research has also shown that there is not a strong relationship between objective measures of disease severity and people's lived experience of symptom burden. This indicates that there are additional contributing factors to breathlessness outside of respiratory impairments alone. We also know that some people receiving optimal existing treatments for their dyspnea still experience significant breathlessness. That's why we decided to consider a novel intervention that targets the brain. So interoception is a person's awareness of their internal bodily signals. This includes heartbeat detection, pain, pupillary response, and in this case, respiratory timing. Previous research has demonstrated that interoceptive tasks that focus on increasing this awareness has led to higher activation in the anterior insular cortex, a brain region that is associated with lower symptom burden in people with COPD. We therefore aimed to decrease breathlessness using an interoceptive priming task and hypothesized that interoceptive priming would decrease breathing effort ratings. So how do we do this? So we start with quite the battery of baseline measures, including questionnaires assessing breathlessness, depression, anxiety, as well as some pulmonary function testing. Then we move into baseline loads testing and questionnaires. So participants breathe through a mask that's connected to a two-way valve. There are a total of 6 different plugs, which we introduce to the inspiratory breath every 2 to 5 breaths for 1 breath at a time. The plugs range in size to make it harder to breathe in to varying degrees. After each loaded breath, we ask participants to rate their effort to breathe on the modified Borg scale from 0, nothing at all, to 10, maximal effort. While they do this, we measure how they're breathing, their heart rate, CO2, and lung muscle activity. Then we give them 2 questionnaires to assess their breathing sensation and mood while breathing through the mask. Then we do one of our computer tasks. So participants will either start with the interoceptive priming task, which involves them watching their own breath trace on the screen, which is emitted from an abdominal respiratory band. In half of the trials, the trace is delayed by 400 milliseconds, and in the other half, it is synchronized with their breathing. And then we ask participants after each trial whether or not the trace was delayed. Or participants will start with the extraceptive control task, in which participants watch the same breath trace, but instead they're looking for a red dot, which will flash up along the trace in half of the trials, and then we ask them after each trial if the red dot appeared. Then we will repeat the loads testing and the 2 questionnaires to see if their breathing effort, breathing sensation, or mood has changed. Then we repeat the same task, loads and questionnaires again, and then we repeat the whole process again with the other task. So far we've collected data from 18 control participants and 8 COPD patients, with a goal of 20 participants for each group eventually. So preliminary results. So here you can simply see the load number plotted against the Borg rating for each of the 4 conditions. And as expected, Borg ratings increase linearly with load number for controls and for COPD patients. Here, we've calculated the pressure time product for each load based on the duration and pressure of the breath through the load. So in controls, we found a decrease post-priming regardless of task type. So Borg ratings were lower post-priming than pre-priming for both intraception and the extraceptive control task, but only by 0.1 of a Borg. And we found the same for COPD participants. However, the magnitude of change was greater, with Borg effort ratings decreasing by 0.7 of a Borg post-priming. So to conclude, while changes in Borg effort ratings are not quite clinically significant, data collection is not yet completed. No difference between intraceptive and extraceptive priming was unexpected and may be due to inadvertent intraception, as the breath trace was visible in both of the tasks. Most importantly, we showed breathing effort can be changed acutely following a short priming task, opening avenues for future intraceptive interventions to modify breathlessness. Thank you so much for listening. I'm happy to answer any questions, and if anyone would like to discuss further, I've also put my email up on the screen.
Thank you very much. Okay, we'll open the floor to questions. So I'll oh, sorry. Mina, please go ahead.
Yes, thank you. Thank you, Andrew. Molly, thank you so much for that, for the presentation. And I'm just curious about a clinical tool that we often use to provide relief to our patients. We often talk about tracing the corners of a rectangle or tracing the edges of a window in clinical practice, and often patients use it and do find relief, but it's, I think it's quite variable depending on the patient context. So do you think it's one of these intraceptive priming tasks that we're engaging in that process?
I think it's a similar concept. I think definitely it's that getting patients to engage with their breathing and be in tune with their breath. I think with the box breathing, you're getting them to change their breath, whereas intraception is very much about them being in tune, not necessarily changing their breathing, but being in tune with their existing respiratory rate and learning to be comfortable with that. So I think it's definitely a similar concept, but maybe slightly different, but I think it probably works in the same sort of way.
Thank you.
Andreas.
Hi, Molly. Can you hear me?
Yes.
Yep.
Okay, so very nice work, I think. So very interesting task. Well done. And I have one question, Molly, because you said that the so far missing differences between the interoceptive and the exteroceptive task may be related to some inadvertent attention effect on interoception also in this exteroceptive task. So my question would be, would that be further supported by the order of the task? Have you already looked at that? Because I could imagine if they at first have the interoceptive task and know they should sort of focus on their breathing, and they see following the attention with their breathing pattern, whether that sort of carries over to the exteroceptive task, where they also kind of maybe check, oh, is this reflecting my breathing? And also paying attention to their interoception, actually.
Yeah, absolutely. I think that definitely could be a factor, because we're still a little bit early in data collection. We haven't looked at that yet, but we are making sure we randomize the order in which people start. So I think it would be really interesting, definitely, to see if there's an effect of order. We also retake baseline in between each of the tasks as well, so we can look at change from the closest baseline. So I think it would be really interesting to include that as a factor as well.
Okay, thank you. And once again, nice work.
Thank you so much.
We've got time for one more question if there is one. So I'll just ask, so with both of your tests being breathing related and the impact being minimal, what do you see it as a role for just generalized distraction, that they have a cognitive task, either one, that just distracts them from the load perception?
Potentially, absolutely. I think if we, once we've completed data collection, if we find some sort of proof of concept, I think it would be interesting to maybe explore a control task that is very different, that doesn't have that breath trace. So we're not getting any, so we remove the potential of like inadvertent introception. I think at this point it was important that the control task was pretty similar, so participants didn't know which one we thought was going to work. But I would love in the future to play around with that a little bit more and make those tasks really different, so we can really differentiate if it's introception specifically or it's just cognitive distraction.
Thank you. We'll just use another minute if you've got a brief question, Erica.
Yeah, I'll be brief. So I understand that you can have high interoceptive awareness, but then the way in which you respond to that can vary, because individuals can have high awareness, but then it can lead to anxiety in the way that they think about it. So I'm wondering how that plays into your design and if you have a way to quantify that.
I think that's a really great point. We do take mood and anxiety measures immediately after the in between each of the priming tasks. So I think it would be very interesting to see, to look at interoceptive accuracy compared to changes in mood, particularly anxiety, to see if that has an effect on breathlessness. I think we might see a bit of a mediation there, absolutely, where we might see people do interoception and then their mood improves, and then there's in breathlessness, and vice versa. So yeah, that's one of the reasons we took the anxiety measures in between every task, so we can account for that.
All right. Thank you very much, Molly.
Thank you.
Okay, our next presentation is from Eduardo Padrão, and he will discuss the impact of ventilator changes on dyspnea in mechanically ventilated patients.
Hi, everyone. Can you guys see my slides and hear me?
Yep. Thank you.
Okay. So thank you. I'm going to talk about the effect of ventilator changes on dyspnea in patients treated with mechanical ventilation. I'm doing this work with Dr. Beidorf-Cassis and Dr. Schwarstein. Different from other presentations, this work is not concluded. We're going to start, but I'm going to present what we're planning and the protocol. So as we've been talking here, dyspnea is a common symptom in the ICU and outside of the ICU, but our goal is to study the patients in the ICU, and particularly those on mechanical ventilator. And this is kind of concerning because it is often not recognized. It's different from like pain and sedation scales, delirium that nurses usually assess. And during the mechanical ventilation, patients, of course, they also have dyspnea, although we use mechanical ventilation to treat respiratory failure. And there is a meta-analysis with 24 studies that shows that the average dyspnea in different scales, but in visual analog scales, around 5/10. And also, there are some, also after the ICU, there are symptoms that linger, and patients may have PTSD, flashbacks, also impact on quality of life. And unfortunately, only a couple studies evaluated how to improve the dyspnea on mechanical ventilated patients. Oops, sorry. So we're planning to do a prospective study single center at BI, Beth Israel Deaconess Medical Center, multiple ICUs, planned to be a blinded study, and also we're going to randomize some of the changes in a standardized fashion. And we're going to try to blind for the patients, for the physicians, and the researchers. I can explain in more details. But we're going to include patients on mechanical ventilator in the ICU that are awake enough with a RAS of -2 to +2. And a CAM-ICU negative. CAM-ICU is a delirium measurement, validated measurement. So because they cannot be confused, right? And they have to be able to communicate. Of course, you're not going to be able to talk, but at least like point or nod or shake their heads. And we're going to blind for the patients because they won't know what we're doing. And also the physicians, we're not going to know what the RT, the respiratory therapist, is doing on the ventilator. And the researchers will be blinded too. And we're going to look at the impact on the dyspnea multidimensional profile scale. So this is the goal of the study. And this is the protocol. So we're going to include those patients with RAS between -2 and +2, CAM-ICU negative, they can talk, not talk, sorry, communicate. And after including the patient in the study, we're going to get consent, explain the procedure. We're going to check the baseline dyspnea using the MDP. We're going to adapt that, I'm going to explain. And then, because they may be in different ventilator settings, we're going to switch to VCAC, so volume control assisted. So in a way that we kind of standardize the changes. And because they're going to be in different settings, we're going to try to match the VCAC to their equivalent settings that were at the baseline in the beginning of the study. And after that, we're going to check the dyspnea as well. And then will come the randomization. So we're going to change the tidal volume, the flow, and the pressure. But these interventions, they're going to be randomized in a way that we physicians and researchers and the patient, we don't know what order these things are going to happen. And then, so we're going to make the change in the tidal volume, increase by 2 or decrease by 2, increase in the flow or decrease in the flow by 25%, and increase the P by 5. And after every change, we're going to go back to the VCAC at this setting that was here initially. And after we do that, we go and do the next change. So at least we have like a kind of a set baseline, and we can compare the dyspnea and check the dyspnea with each step. And after we do all these changes, each change we'll do about 3 minutes. And after we do all these changes, we're gonna put back the patient to the initial ventilator setting. We did have many ideas in the beginning, a lot of different changes, but because of time, with all the changes, it would take about an hour to do all of this. We end up not including all of them, just the ones that we consider more important. So we adapted the MDP. So we remove basically the emotional part and also the intensity part. We left the unpleasantness and also the sensory qualities. And the outcomes, we're going to look how the MDP change according to the changing tidal volume, the changing flow, the changing PEEP, and also the changing modes, right? Because the initial mode to VCAC, and also when we change from VCAC back to the patient ventilator mode. And also because PO1 and also POC may be associated with respiratory drive and respiratory effort, we're also going to look for that. These are my references, and I'm going to finish the presentation and open to questions, comments, and suggestions.
Thank you very much. So it's one of the roles of this conference is to bring ideas for studies and for grants. And this is great. Interesting study. I'll open it to comments and suggestions and questions. Magnus. I think you're able to unmute and talk now.
Yes, Magnus, you can talk.
Yep. We're not hearing you right now.
Okay, so there's a question in the chat by Devin, so maybe you can take a look at that.
Can you hear me now?
Yes.
Yes.
Okay, sorry. Yeah, thank you for this presentation. A really exciting study. So can I just ask, so these interventions, will they be tested individually in a randomized fashion, like a crossover? So first one and then another, or will it be like a factorial design where you might randomize them like concurrently? I was just curious.
So it's gonna be, so we're gonna randomize the interventions, but all the patient will get all the interventions. Is just the order that's gonna be randomized. And so the randomization is basically because then the researchers and the physicians assessing the dyspnea at the bedside and the patient should be blinded. And also because, let's suppose, if we change the tidal volume first, that may affect the flow later and affect the pressure. So that's why you're randomizing, to make sure one variable is not affecting the other. Does that make sense?
Yeah, great. Yeah, absolutely. Yeah, and good luck. Great study.
Thank you.
Sorry, I'm going to jump in with a related question. How long is each intervention going to go?
After discussion, we came to 3 minutes to be in a kind of equilibrium state, and also because there are so many interventions that we thought that like spending like more than 30 minutes at the bedside would be too much. So we came to about 3 minutes.
Okay. So you have a question in the chat that I think is next from Devon, which was next up. How do you account for ventilator-induced diaphragm weakness when assessing dyspnea?
Yeah, so we're gonna assess for PO1 and POC. That's one of the plans to look for the relationship between air hunger and also diaphragmatic weakness and work effort. So that's how we're planning to do. I'm open to suggestion. I was thinking about ultrasound too in the past, but I think that would take too long, do diaphragmatic ultrasound, but this is how we're planning.
And our next online question before we get to Felix, I see your hand, Felix, is from Alexandra. Can you speak to why the protocol limited the MDP?
Okay, yeah, I think we thought about the different scales, like visual analog scale, numerical scales, Borg, but we thought that MDP would give like the sensory quality and also a visual scale. Some of them are difficult to do at the bedside because the patient cannot communicate, and also because of time. Since we're doing like at least 6 to 7 changes, we're gonna have to repeat the questionnaire a lot, and also this is going to increase the length of the time that we're at the bedside with the patient. So that's why we kind of limited to MDP. But that's something that we've been discussing, and we know the limitations of using only one. We thought about using the RDOS, but then they are awake already, so it would be better. And then they use other kind of signs that are not only limited to dyspnea. So that's why we use the MDP. But I'm open to suggestions and comments.
Yeah, this is a tough population to study. You may be in a similar study that we performed a few years ago. There, we struggled to get more than a finger point to a VAS from the patients. Felix, please go ahead.
So first of all, very nice study and interesting questions. So I'm in my lab, I'm leading a study where I have like a similar design, but instead of having people in the ICU, I have people exercising at different exercise intensity, and we play around with not alleviating dyspnea, but making it like with basically increasing the load on the respiratory system. And people are biking, they have all sort of stuff in front of them, so they cannot talk. So we're using Borgs, but we assess like the multidimensionality dyspnea as well, but we just say, so how strong, how bad, how's your fear related to your breathing, etc. And the people point to the scale. So you're kind of like modifying the MDP, which I think is fine, but just to let you know that I think in a similar setting with like kind of like a similar burden on the participant, that's something you could think about. So that's what Serpol, so our lab's been doing, and I think participant and even patients, they get that pretty well. And we are able to get 7, like all the dimensionality of dyspnea covered into like 30 seconds or less, and people get used and they understand it. So that may be an avenue for you. The other thing is you're playing around with these settings, and I guess that it will affect gas exchange, or maybe not. And since you are doing this, I'm just wondering, like, what's the actual goal of the study? Is it to better understand what's the ideal setting for people under that mechanical ventilation, or is it to better understand dyspnea? Because I think if you want to better understand dyspnea, you want something like, you want the best surrogate of dyspnea, and to see like from a mechanical perspective, and a good surrogate of drive is actually getting some surface EMG, or even better, a diaphragm EMG. So yeah, what's like the main what's your main interest in that study, and how you're measuring or estimating like respiratory drive? Because from my view, and I think there's some recent study that show that the pressure in 0.1 second is can be problematic when you have muscle tension relationship that are changing because of mechanical ventilators.
Yeah, thank you. So let me start with the Borg scale. I think that's great. I'm gonna discuss with Dr. Schwarstein and Dr. Bardorf-Cassis about that. I think it's very good to know that you're taking 30 seconds, so that's great. Regarding the second question, so the goal is actually to be more pragmatic. We're gonna have ABGs prior, hopefully, but of course we're not gonna collect them, and we're not planning to collect like ABGs during the study, but we're gonna use and check the ABGs prior to inclusion, so that the medical team order, just to make sure there is no because severe hypercapnia and hypoxemia is an exclusion criteria. But the goal, I think, is more pragmatic in the sense that, let's suppose I have a patient with ARDS with a limited tidal volume of like 4 to 6, but then there is no difference in driving pressure when I'm putting like them on 4 versus 6. And so to see how I can improve that in the little room that I have. So it's basically being more pragmatic and see like what settings I can change. Making sure that the ventilation is still safe from the ARDS lung protective ventilation perspective. I think would be very interesting to have like other things, like you said, diaphragmatic stimulation or better measurements of effort. But I really think those are great ideas. But I think initially we may start with this kind of small project, and then in next projects we can add that. So I really appreciate the comment.
Yeah, sure. Just quickly, so the surface EMG is like a patch and you connect it. So like it's it's minimally invasive, but yeah, collecting a lot of data outcomes, etc. Like you add layers of complexity. But thanks for your answer.
All right, thank you. Felix, maybe you can guide me on this. I'm just looking at the schedule. We seem to be in front because our next presentation isn't scheduled until 9:03.
Yeah, so we can just so we have a last presenter.
Yeah, we have.
Oh yeah, so
yeah.
yeah, sure. So we'll just move on.
Okay. Since we're a little in front of time, you have one, Eduardo, we'll pick on you some more if you've got a minute. So Devin
Yeah.
Phillips has asked, how could diaphragm pacing stimulation be introduced into this project or future projects? Some work being done with this here in Toronto by Yueying Golinger and the lab there. Care to comment? You haven't even done this study and we're asking about future directions.
Yeah, I think the question is great. I don't have an answer yet, but I'll be happy to talk to Dr. Gallagher. Usually the last question is the hardest one, but I think I think that's a great question. I think I would first see how this project goes, and maybe for the future, try to see how other things we can measure, like respiratory drive and respiratory effort in better ways than just PO1 and POC. I think that would be great. And I know that Dr. Beidorf-Cassis know Dr. Gallagher, so it'll be very interesting to know yeah, how we could work together. I think that's a great suggestion.
Yeah, I think we can take it that getting in touch with that group in Toronto is probably a good move. Thanks, Devin. Okay, we'll move on to our final presentation for this session with Yueying Wang and the effectiveness of mindfulness-based interventions on breathlessness in lung cancer, a meta-analysis. Sorry, do you go by Maggie?
Yes, hello, can you hear me?
We can. Welcome, Maggie. The floor's yours.
Okay. Hello, everyone. I'm Yueying. You can call me Maggie. I'm very happy to present my my completed review recently. This works on the effectiveness of mindfulness-based interventions on breathlessness in lung cancer. I will introduce this work through these 5 parts. We know that lung cancer is the leading cause of cancer burden worldwide, and breathlessness is the most common and distressing symptom in lung cancer. If the symptom cannot be relieved, there may be a vicious cycle of breathlessness, which greatly affects their daily life. Currently, non-pharmacological interventions are highly recommended, and mindfulness holds huge potential. It's easy to conduct and requires less specialized and professional training. But there are 2 main gaps. Firstly, the effectiveness of mindfulness-based interventions is uncertain, and secondly, the current intervention designs are inconsistent. Thus, this review aims to identify the characteristics of mindfulness-based interventions, focusing on breathlessness in lung cancer, and to evaluate the effectiveness of breathlessness, pulmonary function, and psychological distress. We searched 10 main databases for English and Chinese papers. We include adult patients with lung cancer. The study should use mindfulness-based interventions as their intervention. We use strict methods to conduct the entire process. Riemann was used to do the meta-analysis. The subgroup analysis was conducted based on the types of control groups. After the study selection, 14 RCTs were included. 5 English papers and 10 Chinese papers. Most were conducted in China, followed in the USA. In China, they prefer to use mindfulness-based respiratory function therapy. However, for Western, they prefer to use mindfulness-based psychotherapy. Half of the studies indicate the intervention provider is a nurse, and most were conducted face-to-face. The popular control group type is Eurocare, and the intervention dosage ranged from 20 minutes to 3 months. Overall, the included studies showed a low quality, low to very low evidence. From the meta-analysis, patients receiving mindfulness-based intervention didn't show any improvements in breathlessness. However, subgroup analysis showed that patients receiving mindfulness-based respiratory function therapy indicated an improvement compared to those receiving respiratory function therapy alone. For the secondary outcomes, we can see that all have improvements. And the subgroup analysis also highlights the important role of the mindfulness practice. For the discussion, there may be some reasons for the non-statistical results of the breathlessness. As mentioned before, the included studies showed significant methodological variation. Besides that, 1/5 of the studies consider breathlessness as a secondary outcome, which may diminish this statistical power. And Hawthorne effect may be since two studies reported significant improvements in breathlessness with the control group. And I want to say subgroup analysis indicate interesting results. Mindfulness seems to have shown additional benefits. Most of the mindfulness practice involve mindful breathing, which may be beneficial for breathlessness. And mindfulness can make patients more focused and have a better acceptance of respiratory therapy, making people better accept their breathlessness. Last, mindfulness may have the potential to break the vicious cycle of breathlessness, which means improving anxiety first and then improving breathlessness. This review is the first to explore this topic, may provide valuable guidance for future studies. However, we also have some limitations. For example, the significant heterogeneity, limited number of included studies, and low quality and evidence level. But we can see that mindfulness holds the potential to relieve breathlessness in the future. Due to the low quality and evidence of this review, it's recommended to conduct high-quality RCTs to examine the effectiveness. Thanks my two supervisors and all my co-authors for their help. And that's all about my presentation. If there are some questions, happy to discuss.
Thank you very much, Maggie. So we'll open the floor up for questions. So if I can just ask the first one, you looked at a comparison or included a comparison of respiratory-based mindfulness and also the psychotherapy-based mindfulness. Could you describe the difference between those two for me?
Yes, thanks for your question. Particularly, the most popular two intervention types are mindfulness-based respiratory function therapy, and the second one is mindfulness-based psychotherapy. Based on this review, we found that for the mindfulness-based respiratory therapy, is all Chinese papers reported they use these designs, but for the mindfulness-based psychotherapy, only two studies conducted in USA reported these results. And we found why it shows these results by reading these papers. We found for the studies conducted in China, the patients are usually post-operative patients. They do the interventions in the hospitals, especially before their discharge. So after their surgery, they may be mostly focused on their respiratory function recovery. So they designed such study which most focus on their respiratory therapy. But for the mindfulness-based psychotherapy, these studies conducted in USA, the patients most community patients, so not for the surgery patients, they want to use some psychotherapy to help their breathlessness. But I want to say for the studies conducted in USA, one of them indicate that they regarded as breathlessness as their secondary outcomes. So it's maybe they use psychotherapy to for their main study design, I think.
Okay. Thank you. Are there any further questions? Mina, please go ahead.
Thank you, Andrew. Thank you, Maggie, for the presentation. I must first of all plead my own ignorance about the methodologies that you're describing. But essentially from your description, it sounds like when the mindfulness was applied with the respiratory techniques, it was mostly done, I'm assuming, either by physiotherapists or RTs, respiratory therapists. And then the other option with psychotherapy would probably involve psychologists. So when I view this as a clinician, I feel like these interventions are probably quite heterogeneous, and it may not make a whole lot of sense to combine them together and then assess outcomes. What do you think about it?
Yes, thank you for your question. When I did the meta-analysis, you can see the RB results. There is a huge heterogeneity. So I have to do the subgroup analysis, but due to the limited number of the studies, I think in the future, maybe more high quality RCTs need to be conducted to examine these results. And for you may also indicate that the mindfulness combined with respiratory therapy. Yes, I think just I mentioned before, most patients included in this study are post-operative patients. So I think this study design may be most focused on these types of patients. There's also a limitation of this review. We can't extend our results to other stage of lung cancer or other, or they take other therapies. So I think this review just showed some preliminary results, and we need to explore more in the future. Thank you.
Oh, can I add on that? Yeah, thank you, Mina, for a comment. And yeah, this is you really have that point that I understand. Like the interventionists for the respiratory function intervention versus the psychotherapy should be from different person. And this is a good point that we should look into it further. So yeah, thank you. We will work on that. Thank you.
Thank you.
Yeah.
Okay, are there any further questions?